Good afternoon. I'm honored to be speaking with Dr. John Garbutt, Professor Emeritus of Gastroenterology at Duke in the Division of Gastroenterology. Dr. Garbutt was a mentor and a colleague of mine through my training and on faculty, and it's really a pleasure to be able to bring you here and talk to you about Duke in the days when you first came here and how it changed over the time that you were here. When did you first come to Duke?
Be 66.
And when did you leave?
July 66, and I left 1998.
Wow. So yes. Over the course of that 30-plus year reign, what were some of the things you remember most about when you first came, and then maybe talk about what it was like by the time you left?
Well, the way that I got here was kind of unusual. One of the best residents I ever had was the chief of pediatrics in Philadelphia when I was in medical school. And he said he really thought a rotating internship was the best thing to do. They probably don't even have them anymore.
Not that I know of.
But 5 of us from Temple Medical School decided to do that and went to Jacksonville, Florida, to Duval County Medical Center, which was the public hospital, to do rotating internships.
So rotating internship is where you do multiple different
you change
medicine
things.
And pediatrics and surgery.
To give you a quick idea about what that was like, the day I arrived, July 1st in 1966, I walked in, the resident met me and said, "We'll make rounds in a couple hours, but I'm busy. Go over to bed 18 and do a tracheotomy on that guy." I'm serious.
Wow.
And I said, "Are you serious?" And he said, "Yes." So I went to the library, got a surgical book that had tracheotomy in it, and went over, did the trach, and then met him and made rounds.
Wow.
Another part of that OBGYN rotation was 6 weeks, and I delivered about 300 babies in that time. Surgery, we did all sorts of stuff. Pediatrics, same. But it was a great experience and let you decide what you really wanted to do. And by then I had met a fellow named Jim Borland who taught there and who had trained at Duke with Dr. Ruffin. So that was the first connection. It turned out the chief of medicine in the hospital was Max Michaels, and he had trained under Dr. Stead at Duke. So there were 2 Duke connections down there. And then I got drafted.
Oh.
So I went in the Army for 2 years with the 11th,
with medicine?
11th Air Assault Division, and I was company commander of a medical company.
Wow.
And it was the first unit that the Army flew, so we flew all over the place training to go to Nam. Luckily, it wasn't declared a war yet, and after 2 years I was allowed to get my discharge and go back to training. But at that time I said I'll never fly again. I'll get to that later. But anyway, I went out and I went back to Duval Medical Center for a year of residency. And Jim Borland was pushing me then to come to GI training at Duke and with Dr. Ruffin and come back and join his private practice.
Okay.
So that was the situation.
In Jacksonville.
Yes. So I came up here after my year of residency, and 2 in the Army and an internship, right? And I interviewed with Dr. Stead, who was chief of medicine. And he told me to see him at 7 o'clock the next morning in his office, and to make sure I talked to the chief resident the night before. I didn't know why. So at 7 in the morning I went into Stead's office and sat down, and he just looked at me and I looked at him. It seemed like forever. And he finally said, "Don't you have anything to say?" And I said, "I thought you were interviewing me." And it cracked him up. And I knew I was going to get a job.
Wow, but it could have gone either way.
Oh yeah. And then he said, "You will start as an intern."
Oh.
And I said, "Oh really? I've had 4 years already." He said, "You'll start as an intern if you want to call your wife and see if she'll agree." And I said, "No, she'll agree." So I said, fine. So I started as an intern
Oh,
on Long Ward and Osler Ward. After a while, somebody got a little anxious, one of the interns, and dropped out. And I went back on Long Ward. But at any rate, after 6 months, Stead came and said, okay, now you know where everything is in Duke Hospital, is that right? And I said, yeah. And he said, that's why I made you do that. And he said, maybe you didn't notice, but I was paying you as a resident.
Ah.
So anyway, he said, now you can start your fellowship.
Wow.
So I went with Dr. Ruffin. And I had 6 months with Dr. Ruffin. A little background there. Dr. Ruffin was one of the first GI doctors to come south from Johns Hopkins.
Mm-hmm.
Borland was the other one in Jacksonville. Dr. Ruffin had ties to the Confederacy.
Oh.
And he loved to sing old Southern songs, and he wore a vest which was a Confederate flag. He was quite a character.
And he was the clinician.
Yes, totally clinician. Any research was clinical research, which he wrote a lot of papers.
Mm-hmm.
And the deal was we met in his office at 7 a.m. every day, the fellows, and there were 4 or 5 of us. Went over the day's thinking, then went and did the procedures, came back to his office at noon. Everybody had a Coca-Cola and some crackers and discussed the afternoon activities. And at 1 o'clock, Dr. Ruffin went home. His wife had Alzheimer's, and he went home and took her for a ride and out to lunch every day, and came back at 4 or 5, finished the day talking about what we were going to do the next day.
Wow.
And we did that every day of the week. Rain, snow, anything. He was in that office at 7 a.m. So that was great.
So what were the procedures you were doing at that
And
time?
at that time, we had a proctoscope,
Mm-hmm.
which was a steel tube.
Mm-hmm.
We had NG tubes, of course, and we had a stiff esophagoscope.
Oh.
And proctoscopy was the start. There were a couple things about that were interesting to me. One of them was you always prepped the patient before you did a procto.
Mm-hmm.
And I had my mind made up that a lot of times the stool was guaiac positive, and I didn't want to have a prep where it made it guaiac positive all the way up.
Mm-hmm.
So I would do them unprepped first,
Oh.
take a stool from above the anus.
Uh-huh.
If it was guaiac negative, I knew pretty well it was bleeding down low and it was probably no problem. And then I would prep them and do the regular proctoscope.
Wow.
So that was just one of my little things.
Inventions, yeah, good.
It took a little longer because you had to
Right.
clean up twice.
Right.
But anyway, and from there we went to the flexible sigmoidoscope,
Mm-hmm.
which allowed us to look further and had the lens.
Mm-hmm. But with the teaching head, right?
But
You
at the beginning it only had the lens.
Okay.
So when you were trying to teach, and that was the same with the colonoscope, you'd look at something and then pass it
Pass
over
it
to the
on.
fellow, and it might not be the same
Right.
image.
Because now you change the.
And you
yeah,
go back and
rotating.
forth and never sure that he saw what you were seeing.
Wow.
Then we finally got the one with 2 lenses. And as you know, it progressed until I could look at on the TV screen
Mm-hmm.
fellows doing colonoscopies in 2 different rooms,
Right.
or 3 actually.
Right.
And they could stand there with you and look on the screen. It was much better for teaching.
And for safety too.
Yes, yes. So that made a huge difference. And I think I mentioned it, but at that time the Pink Ladies that ran the snack bar would give money to a clinical research project, but not to a laboratory project. And I got them to buy the first colonoscope at Duke, which they did.
Mm-hmm.
And so that's when I started doing that.
So you did the first colonoscopy
Yeah,
at Duke.
yes.
Do you remember how much roughly the first colonoscope cost?
I think it was about 9,000, somewhere in that ballpark. It was close. The Pink Ladies gave us 10,000,
Wow.
and that allowed me to buy all the stuff
It's
for
impressive.
it. Yeah.
And look how many colonoscopes we do Just a year
Yes.
here at Duke.
Yes, it rapidly became the thing to do. It probably hurt the radiologists more than most people.
Although I don't hear them crying about not having to do barium enemas
Right,
anymore.
right. That reminds me also, when I started seeing patients, I met every morning at 7:30 with the radiologist, which was Dr. Reed Rice and Dr. Freddie Kelvin, and we went over every x-ray on my patient that had been done the day before. So outpatients and inpatients.
Wow.
It took us an hour or so. But we reviewed all the x-rays. Then I would make rounds. Then I would teach or do endos myself. And then at 4 in the afternoon, I met with Dr. Butts Fetter, who's the pathologist who did all the GI biopsies. And I went over all the biopsies with him. So it was a great way to learn both how to read the x-rays and
The biopsies.
do the biopsies.
Sure.
So that was
Wow.
good for me in terms of learning. Along the way with the radiologists, I guess while I'm thinking of it, they were working on barium, air contrast barium enemas, which were going to be better than a regular one. And although some wouldn't like this, I did colonoscopies on dogs, and then they did an air contrast BE, and we compared what we each were seeing. That's how they started the air contrast barium enemas before we
Interesting.
did it on humans. But it turned out to be a good way to evaluate the colon
Sure.
if you had to do the x-ray.
Right.
So,
Better. Yeah, better than single contrast.
so I worked with them very closely. Actually, Freddie Kelvin married my physician assistant,
Huh. Who
and-
was that?
Anne.
Valancourt.
No,
No.
it was the one before her.
Oh.
I'm trying to think of her last name, but Anne anyway, and she's Ann Kelvin now.
Wow.
But when they left for Indiana. Then she left me, and Ann Valancourt became my next physician assistant.
You know, Anne is back here in hepatology.
I did not know that.
I heard her voice. It's an unmistakable voice. And
Wow.
I said, that is Anne Valancourt.
I'll be darned.
And she had gone to work like
In Chapel Hill, in
yes.
family practice.
Right. She's
Yeah.
back now working in the
Really?
transplant group.
Well, that's great.
It has really came full circle. That
Yep.
was nice.
Yeah.
Yeah.
Yep.
So go back. You took me to your initial days with Dr. Ruffin as the
Right.
clinical fellow, and then did you do a
and-
two-year fellowship? Or?
Well, not really. This is again Dr. Stead, but I did the 6-month internship, and then I did 6 months with Dr. Ruffin as a clinical fellow, and then I got labeled a research fellow in gastroenterology, and I went in the lab and started to do the biosalt business with Dr. Tyre. And Leon Lack, who was a pharmacologist, helping out because he knew the chemistry. And I did research on bile acids for the next several years. But after 1 year as a research fellow, Stead came and said, how about joining the faculty? So, of course I said yes. Carol and I, my wife, decided we'd like to stay in Durham, where I loved working with people that were good. Although Jacksonville would have been good too, but we decided to stay at Duke. So I said okay, and Stead made me an associate in medicine. The only reason that was of interest was when I went to take my boards, I had not had 2 years of GI fellowship. I had 18 months. And I had not had 2 years of internal medicine residency. I had 18 months. And Stead said, forget about it. I'll take care of that when they ask for your CV. And if you look at my CV, it says I was a medicine resident 1967 to 69, and you go down 2 notches and it says I was a GI fellow 1967 to 69.
Oh.
The same 2 years.
Oh, wow.
When I took my boards, they never looked at that, so whatever. But that was Dr. Stead. From what I understood, he never took the medical boards.
Oh, really?
He didn't think anybody was smart enough to ask him questions, I think. But no, he never took the boards.
Wow.
even though he was a very famous chief of medicine. But anyway, yes, then we went for the bile salts. And that was down here, near here. We had a lab. I had a lab with the chemical part of things and a radioactive counter. And then we had a fluoroscope x-ray room, and that was next to the conference room down here and right near my office and everybody else's office. And what we did was inject radioactive bile salts, then bring the patient into the x-ray room and put an NG tube down into the duodenum. So you had to learn how to get it in the duodenum instead of the stomach. And once you got it there, you gave cholecystokinin, which emptied the gallbladder, and you collected all the bile, took a sample, put it all back in, and you had the patient come back every day for 3 or 4 days, and you kept pulling the bile out, and you could measure the radioactivity, get the half-life and the pool size, and see how it was conjugated.
Wow.
So that's what we were working on, and that started my interest in the ileum, because that's where they were reabsorbed. And got me into thinking about Crohn's and ulcerative colitis. And at the same time, they were doing dietary for obesity surgery, doing jejunocolic bypass, and they all had terrible diarrhea. And so I started working with cholestyramine, Questran, to help them with their diarrhea. But it also gave me lots of patients with bile acid loss, because they had to they didn't have a place to reabsorb it. So we got into that. That's where I found out the GT ratio changed. The liver preferred to use taurine, but it ran out. So all the bile salts became glycine conjugates. If you gave a dose of taurine, it would change back to taurocholate. It didn't, at the time, we didn't know any benefit from that. And we tried to figure one out. Along the way, of course, you realize that the bile salts dissolve cholesterol, and we got interested in trying to treat gallstones, because most of them are cholesterol stones. That was sort of a dead end that didn't work. But one reason was, of course, if the stone's sizable, it would take forever to dissolve it in bile acids that you gave people. Plus you gave them diarrhea. But then ultrasonic came along, and that we thought might help, because the stones would be made smaller, they'd be cracked up, and we might dissolve them faster. But then laparoscopic cholecystectomy came along, and that was so quick and safe, most patients just said, take the gallbladder out, and that was the right thing. And we stopped doing research to dissolve stones, because that was not going anywhere.
Did you use the lithotripsy machine here?
No, I didn't.
John Affronti used that, I think.
Yeah.
But that quickly became sort of a white elephant that we had to sell for parts.
Right, that's right. That's right.
Wasn't used too much.
Same reason. Yeah, it got me the gallstone studies got me a trip to Phoenix, at least. At way back now. It was learned that the Indians in Arizona had almost 100% incidence of gallstones in the ladies.
Really?
Yeah, almost every lady, 15 years old and up.
Really?
Yep. And so Tyre sent me out there to the laboratory that was working to help them learn how to measure the bile salt pool and to see if they could figure out why all these ladies developed gallstones. So I got 2 or 3 weeks in Phoenix when it was 105 degrees, I might add. But had a good time working in the lab and with the people, and then came back here.
Did you figure out why?
No, we never got there, because I was teaching them how to measure it, but then they were going to work for the next year or so to measure the bile salt pools. I think they gave up on it before, for the same reason.
Wow.
I mentioned when I got out of the service, I said I would never fly again.
Right.
And I didn't for quite a number of years. I drove everywhere we had to go, to the AGA meetings.
Really?
Yep, every place for a number of years. One of the fellows behind me, Mason Wilkins, was his
I know
name,
that name.
was practicing in Idaho. He had been with Ruffin the year after me. He called and wanted to go fishing in Canada, way north Canada, and I'm a fisherman. So I said, okay. And my daughter Jolyn, who was 16 at the time, was going to go with me. Mason and his son, and Ken Rockwell, who was a psychiatrist here at Duke, and his son. And I tried to back out, and my daughter said she's going anyway.
Oh.
So I said, well, then I'll fly with you. So we flew to Winnipeg, drove up, rented a car, drove up to this place where the float plane was, got on the float plane. The pilot was smoking a cigarette, went down the lake and didn't make it on the turn, landed safely again, and came around, lit another cigarette. I opened a beer, which was about 6 a.m., and so did all my friends who had been laughing at me for fear of frying.
Right.
And he took off and dropped us on an island for a week and said, if you have any troubles out here, just circle the canoe around and somebody might fly over and see you. We had no telephone, no electric,
Wow.
nothing. So we caught fish and grilled them, bathed in the lake, had a great week, and I came back and I started flying again.
Oh.
So from then on, I could accept these offers to go give a lecture someplace,
Right. Right.
all that, and we ended up going all over the place, as you know. So that got me going.
Speaking of lectures, do you remember in the early days of the clinical trials, and we've talked about this, one of the first trials for a drug that later became known as Remicade or infliximab, we conducted here. And the company came and they wanted background on Crohn's and ulcerative colitis, in particular Crohn's, and they wanted someone to give a lecture, and you gave them the lecture. Do you remember doing that? They were mesmerized.
I didn't have anything to do with the drug, with the studies, but I did give the lecture on how you tell the difference between the two, and that was one of my favorite things. And it all came about from looking at the x-rays with Reed Rice every day and the biopsies and my interest in it and the bile salt thing. So it was to be involved with small bowel disease, I really enjoyed. And that was the same with Whipple's disease, any kind of small intestinal disease. But yeah, I remember giving them that lecture.
That was probably 25 years ago.
Yeah.
Well, the drug was approved in 1998,
Right.
so it was probably in the mid-90s.
Yep.
And they talked about that lecture for years after. So they were
Well,
thrilled by what you taught
I'm glad
them.
to hear that. It was interesting. CME, continuing medical education, do you still do that? Do you have to do so
Yes.
many hours and all that? Well, in the beginning, you got invited to go around to various little hospitals, and a lot of people didn't like to do that. And I thought that's the way to grow my practice.
Right.
So I went to Oxford and Henderson and Danville and Martinsville, all over the place. After work, I'd drive there, we'd have dinner. One of the drug companies would support the dinner for the doctors, and you'd give your talk on whatever you wanted to, and come home. And that exploded into taking 1,000 doctors to a resort somewhere
Right.
and doing their CME for a
Right.
week.
Right. Which now they can't do either. But
That's right. Now it's.
we've come full circle.
But that I went through all of that, and one little story on that one, I guess. With Dr. Ruffin, we were looking at anticholinergics for ulcer disease, and we tried to decide how much gastric acid you made overnight. So 4 of us volunteered. I put an NG tube down all of us in Ruffin's office,
Wow.
hooked us up to the pump, and we collected our acid overnight and played bridge all night long, which was crazy.
Wow.
And then the next night we did it after taking ranitidine, I think was the anticholinergic at the time. So that was the first drug study that I was involved in.
Wow. So the first drug study you were involved in was a
Self-induced NG tube
NG tube
to measure my acid secretion
for how many hours?
all night.
All night.
It was all night. We played cards all night. And one night we had took the drug, the other night was the placebo.
Placebo, yeah.
And 4 of us. So that, and Ruffin wrote that up somewhere. But anyway, that was the first one of those things.
So no IRB.
No. And then the drug reps started to come around, and I worked with Tagamet for a while, and the GI division got the money. I didn't get the money, but they paid us to do the studies. I worked with Tagamet, then Glaxo came around, and they had Zantac. So I worked with Zantac and did various studies on ulcer healing. You endoscope them before and after and see how fast they heal. And then Merck came, and this was one of the fascinating things to me, because Merck came with Pepsid, which was another H2 receptor blocker. And I started giving lectures for them, and I went to them and I said, what in the world are you doing? You're competing with 2 other drugs that do the same thing that have been around a while, and this isn't going to be any different. It's just another
Me too.
Me too. And they said, oh, we know what we're doing. Well, what they had been doing, which I didn't know, was asking the doctors that you lectured to grade the lecturer. And then they selected who they wanted for their new faculty in gastroenterology. And I got selected, luckily, of many. There were quite a few, but anyway. And then they brought omeprazole out and Prilosec, and they were just getting us ready to talk about ulcers and reflux esophagitis before they sprung the new drug. So I was right in the front with omeprazole, which was a great drug, and still is.
Right. When you started these,
and then I went all over the place.
Yeah. Did you have any inkling that these drugs would be available over the counter?
Not a chance. In fact, it was hard because a lot of doctors didn't even want to try anything new. And they really thought if you made somebody achlorhydric, you might give them gastric cancer. So there was a lot of that.
You could only give it for 8 weeks at a time.
Right.
And then patients would come back saying, I have to be on it.
Especially with heartburn, reflux patients, especially.
Yep.
But I got to do that for Merck, and continued to see the local folks, but also got flown all over the California and Arizona and all sorts of places to do that. And that since I was flying again,
oh yes, right,
it didn't bother me. And I could take Carol with me, and we would go. So,
tell me about the VA. You mentioned earlier what the campus connection was like, but has there always been a close relationship between Duke and the VA in the GI divisions?
Yeah. When I first got here, after I was in the lab here in Duke South, and they put me on the faculty, I got a lab at the VA. And when I went over there, the chief of GI was Bill Dobbins, who later went to Washington, D.C. at the famous hospital there, I forget what it was. And Paul Webster was doing research on the pancreas at the VA. He went to Georgia later. And then there was me, and there was a doctor named Steve Quarford, who was a cholesterol guy. So there were 4 of us that were full-time VA. I saw most of the patients. The other guys didn't. Bill Dobbins liked to look at the biopsies and taught me a lot. Webster and Quarford stayed in their lab pretty much. And then I saw patients and did some bile salts over there. So there were at least 4 of us at the VA and the fellows that were with us.
So you mentioned earlier, before we started talking here, about what the walk between Duke and the VA was like.
Back then it was woods. It was right through a pleasant forest on a dirt path from Duke South to the VA hospital.
So was Irwin Road?
Irwin Road was there, but not very busy.
Yeah.
And nothing else.
And so you sort of wound around behind the VA in the woods and ended up at the VA.
Yep. And just came across, and that went over there almost every day when I had my lab over here. And then we did all our thing there. It turned later, both Bill Dobbins and Webster offered me jobs because they had become chief at Georgia and DC, which I didn't want, but I did visit him. And Crawford left and went somewhere. I forget where he went.
I don't remember.
But then the new crowd came in, and I was pretty much, well, that was the other thing that happened. I guess I better say this too. While I was over there, my wife had twins, so now I have 4 kids. My salary was $13,000, I think, at the VA, or 10 at Duke, which neither one were real good. But McLeod was getting tired and had been the only guy. Ruffin didn't see nighttime stuff, so Mike was doing all the night call. And he decided to go on sabbatical. And Stead called me and said, what do you think about becoming a clinical gastroenterologist and not be in the lab? And I said, I'm thinking pretty seriously about that because my family has grown. So he said, okay. And he said, McLeod's going on sabbatical for 6 or 7 months, and you can take over. So I was on call for 6 months, and every night. Every
Monday
weekend, every
through
night.
Sunday, I mean, weekend,
Every single night. Nobody else took call.
And this was for inpatient, so you...
Everything,
any consult?
inpatients, consults, and I admitted them to my service, so I had 7 months to develop a practice and work. And then when Mike came back, we split it. So we were every other night, every other weekend, forever it seemed. But one of the sort of things I thought about recently was I never saw Mike's house here in Durham, and I don't think he ever came to mine because we were always on call.
Oh, right. You could never
Right.
be off on
We did
at the
not
same time.
do anything socially together. He had a cabin about a half mile from mine on Carr Lake. I never saw his cabin, and he never saw mine. And
Now, did you have fellows coming in at night also with you at that
yeah,
time?
yeah, yep. And
But
so when
still.
an emergency came, a GI bleeder or something like that, the fellow was usually called first, and then they would call us,
Right.
and we would
But you
come
had to
in
come in,
to do the
right.
procedure.
Right.
And we did that all the time. And of course, if they got admitted to our service and went on. And so Mike and I never did anything together, but we were friends. We didn't. It wasn't a competitive thing.
Right. Well, you were never off together. You were one
Right.
was on, the other was
Right.
yeah.
So
I can remember when I was an intern and resident, if we had a patient, an inpatient who needed a GI consult who wasn't in an ICU or otherwise unable to travel, we had to bring the patients over to Area B, the blue
Yep.
zone, and
Yep.
they would wait in a wheelchair for you or Dr. McLeod to work them into your clinic.
right. And we tried to make sure that our patients understood, because we never knew how many were going to come
Right.
over.
Right.
So I always told my patients, and so did Mike, that they may have to wait a while because I never knew who was coming across the street.
Right.
And they understood, and Ann Valancourt was very good as my PA, and she would go in and talk to the patient and take a history and physical while I was working on one of the consults.
Right.
So she could take up their time and keep them busy.
But the same was true when a patient needed to be scoped, right? Because
Oh, yeah.
you would have to leave your clinic to go scope a bleeder or...
Yes. If you had to go to the
you had
ER
to
or
go.
something like that. If they could make it, they would come over and we'd scope them
Right.
in the same area. That's
so
right.
in your time as chief of endoscopy, what were the biggest changes that you saw?
Colonoscopy
Yeah.
was
And
one.
then when in your time did Dr. Cotton come?
Way after that. Yeah, that was way after that. During my time, I started doing esophageal dilatation.
Okay. I think you told me you did the first esophageal dilatation at Duke.
Probably. Well, the surgeons were doing them,
Sorry.
but not the way we did them.
Right.
And we could go down with the scope and put a line in and put it where it was supposed to be and do it.
So the surgeons were doing
Blind thing.
a bougie, a Maloney?
Yep.
Or, okay.
Yep. And often the thing would go down and turn up and go the
Right.
other way. One of my favorite patients with that was a guy that owned a red and white grocery,
Oh, yes.
Billy.
I took care of his wife.
and Billy could not swallow any solid food for several years. And I won't say who the surgeon was, but the surgeon was dilating him all the time, but he never got better. And so Billy came in and I saw him, and when I scoped him, he had like a pinhole in his distal esophagus from reflux. And I said, I can work on this. It's going to be tough, and it's going to take me a while, but I'll get you open, which I did. And he called having steak and eggs on the back of the red and white grocery. And he delivered food to our house at Christmas and Thanksgiving all the time. Bought fish from me when I came back. So we got to be buddies.
Wow.
But yeah, I got him open. We did the first pneumatic dilatation for achalasia.
Was that scary?
Yeah. I was afraid I was going to perforate somebody, but we did it. We did the first sclerotherapy for varices during that time, and laparoscopy we got going, and Paul Killenberg took that over for a while. That became, it was going. That wasn't very popular.
Right.
But anyway, so
where did you do laparoscopy?
In the endo room.
Really?
In the endo clinic. Yeah. So that was that part of things.
And it was diagnostic?
Yes. Yeah.
Could you take a liver biopsy?
You could do liver biopsy was the main reason we started doing it, because you could look at the lesion and hit it exactly instead of blindly doing a regular liver biopsy. So but it took so much longer and so much more technical stuff.
Right.
It got where the surgeons would just do it, and the radiologists could do it too, with CT scanning and ultrasounding. So that changed that one. But we did that first too.
Wow.
And we started ERCP. McLeod did the first ERCPs here.
Oh, really?
Yeah. And I did some also, but it wasn't my special interest. And that later, that's when Peter Cotton came, and that was his deal. So that changed that whole thing.
The focus of
Yes.
Right.
Yes.
So how did things change between? How long was Dr. Tyre the division chief? Maybe 20
quite a long
years?
time, 20-some years, sure.
How did things change when he retired and Dr. Taylor took over?
It was probably already beginning to change. And this is a financial issue, but if you want me to talk about it, I will.
Sure.
Because it did affect me. Way back in the beginning, they had a group called the Department of Internal Medicine, DIM group, which McLeod and I were in. All the clinical people were in it. And we were not paid salary. We were paid commission with a special contract that if you brought in $20,000 your first year and $40,000 your next year, you would get 30, and the Department of the DIM group would keep the 10. So each year you would go up halfway as you increased your practice. And the idea was that when you retired, you would go out halfway each year as you decreased your practice. So you had kind of a safety net, but you also could make more money if you really got going with something good. The first one that got going with something good was cardiac cath. And they took him out of the DIM group and decided to pay him accordingly because he would make too much money.
And who was that?
I'm trying to think. I think his last name was Anderson, but at any rate, now Weingarten at that time was chief of medicine, and when I joined the DIM group, he told me that I would get 40% of my endoscopy, which took about 2 months when I did 20 colonoscopies a week. He called me back in and said, we can't do that because you'll be making more than some of our oldest DIM group members, and that's not fair. So he cut back on how much I got per endo, which I said fine, because I was comfortable and everything was okay. Now the thing that happened, now of course Mike and I saw all the consults. So we saw all the public patients who didn't pay, all the private patients, but we knew we were doing things. Now, two things happened. When Joe Greenfield became chief, he didn't like the DIM group very much because we controlled a bit of power.
Mm-hmm.
And he went about voting to get rid of the DIM group. And I was just about to become chairman of the DIM group because I was financially savvy.
Mm-hmm.
But the vote came before I got to be chairman. And he had gotten the retiring guys to vote to get rid of it with whatever. But anyway, so they got rid of the DIM group. And that meant we had to go on our own.
Mm-hmm.
And around the same time, especially when Ian came along, and I'm not blaming him for this because some of it was for the good. But for instance, Scott Brazier became the esophagus guy,
Mm-hmm.
which was great, and he was the best. But that meant every cardiac cath patient that came in who had a negative cath, Mike and I didn't get to see them for the consult.
Mm-hmm.
Scott got to see them. So that cut into our paying population.
Right.
Every biliary tract patient got
Right.
to cotton for ERCP.
Right.
Every liver patient got to hepatology.
Mm-hmm.
And so it changed the
Sure.
scenery. And what it basically did for me and Mike was increase the number of public patients we were seeing, because those guys didn't see so many of them,
Mm-hmm.
which we didn't get paid for. So our salaries actually started to diminish.
Mm.
And that was one of the factors in my retirement.
Mm-hmm. Right. Or what are things you're most proud of, like the teaching of the fellows,
Yeah.
or because to me that's because that's how you impacted me the
Yeah.
most.
We okay?
Yeah.
All right.
Yeah, I think, getting colonoscopy started was one of the favorite things. Teaching was favorite thing. Having the fellows all come along and learn about them and try to help.
Mm-hmm.
I really enjoyed that. And that's really one of the reasons I stayed.
Mm-hmm.
And I tried to teach it in a rather broad way, I guess.
Well, I will say that having been here for a while, but having been one of your trainees, one of the great gifts of that you had was your breadth of knowledge, depth and breadth. But now we are in an era where everyone has a very focused, a focused area of interest. And
Yep.
I would say for myself, our ability to teach on subject matter that is not our area of interest is much less, whereas you were the person who knew something about everything.
Yeah.
And I remember Steve Goriska once said to me, he said, Dr. Garbutt, pound for pound, he's the smartest guy in the division. And I think he was right. I mean, there were
that was
times
nice.
when we would round in your office, and you would be opening your mail while I was presenting a patient, and I thought, he's not listening. And then as soon as I stopped talking, you would say, I know what this patient has, and you were right almost all the time. And I can remember thinking, how did he do that while reading your mail? So it was a good skill.
Well, thank you for saying that. It really was very important to me to be able to teach, and that's, of course, the reason I stayed here.
Sure.
And it also got out of the lab and into the clinical side of things. That it wasn't just money.
Right.
It was what I enjoyed doing. And it might have had something to do with having a rotating internship
Yes.
and doing the crazy stuff.
Right.
I mean, like I said, I did a tracheotomy and I did all kinds of surgery and all those deliveries. One of the things that I did, which got Tyre very mad, when I was a quotes intern on long ward, one of my patients I knew needed a liver biopsy, so I did one. And Tyre came up with the GI fellows to round on that patient, and he said, well, I think we need to do a liver biopsy. And I said, I already did it. And he went nuts.
Wow.
He said, you're an intern. And I said, yeah, but I've done more than these fellows have.
Wow.
But he didn't like that at all. And I was told not to do any more liver biopsies until I became a fellow.
Wow.
but that just happened.
So if you think back on the fellows when you started, there probably weren't many women in the fellowship.
No, and it became many.
Mm-hmm.
Your
Yeah, right.
level were all sorts of ladies.
Right.
Way back, maybe the first one was Sadie Curry. Could have been. Do you know Sadie?
I don't know Sadie.
Sadie was a black girl,
Mm-hmm.
and very good. And she was a fellow and went to Washington, D.C. I lost track of her, but she was still doing GI. I know that.
In private practice or
I think
academic?
academic, I think. But I don't remember any more until you and Carol Petros.
Yeah. Well, there was Debbie Skelton.
Yeah.
Skelton, I think.
Yeah.
I'm not sure if that's her name, and maybe one other, but very few women.
There's Colleen. There's the girl in Pinehurst.
Diane Williams.
Diane.
Mm-hmm. Mm-hmm.
But that all happened at once.
Right. An explosion.
Yes.
Mm-hmm.
Yeah.
Yeah.
Yeah,
there weren't even many women faculty. You had Jackie Hymans was your only, and then
right.
Joanne Wilson came.
And Joanne.
And now
there's many, right?
Proportion of the division is, yeah.
And we've had a lady chief of medicine and chief of GI.
Yep.
Yeah, times have changed considerably.
Mm-hmm. Mm-hmm.
Yeah, that's an interesting
mm-hmm.
take on things.
Peter Cotton's book, one of his books, has a line, why aren't there more female gastroenterologists, with a question mark. And when he was leaving, I asked him to sign my book, and he flipped to that page and he hand wrote, I know why. Anyway,
yeah.
sense of humor.
Yep.
So thinking back, you mentioned some of the biggest changes or the biggest accomplishments of your career, and one was doing the first colonoscopy.
Yeah.
Can you think of any other things that you were particularly?
Well, I started the IBD clinic,
right.
which
that's right.
You took over for me, thank God.
And I think that was.
I started that. I had a golf tournament for IBD.
Really?
Way back. Yep.
I don't remember being invited.
And I think it might have been before your time.
Sure. And I don't play golf.
And we did it a couple of years. I had a number of patients in Durham that played golf, and they were perfectly willing to sign up and contribute to the cause.
Would you do it again now?
Probably not.
You still play?
Not at my age. I don't play much anymore.
You don't play.
I used to play a lot.
Mm-hmm.
And all the drug reps played golf,
mm-hmm.
And still do.
Mm-hmm.
So I played with the Tagamet guy and the Glaxo guy. Still play with the Glaxo guy. Jerry McKinney.
Oh, yes.
Was the Glaxo rep.
Wow.
But I played with a lot of doctors.
Mm-hmm.
When I gave those little talks.
Bring your clubs.
Yeah, and after they got to know me, we would play in the afternoon, and then I'd give the talk, and then I'd come home. But quite a number of them invited me to play in their member guests.
Mm-hmm.
So I played with a number of them and some of our fellows.
Mm-hmm.
Bob Mitchell was a good golfer.
Oh, sure.
In Richmond, I played up there with him a couple times at his course,
mm-hmm.
And he played at mine. Tom Kenny was in Boston.
Mm-hmm.
Same thing, he's a good golfer.
So many of these people, if I'm not mistaken, came back for your...
Some. Bob Mitchell did,
mm-hmm.
and Tom Long.
Right. Came back for your 80th birthday party.
Yes,
mm-hmm.
yes. Frank Pancotta did
mm-hmm.
not. He was down there with Long for a while. Yeah. Dr. Stead, I think, got Tom Long
mm-hmm.
going in Concord, North
right.
Carolina, and it was a great move.
Yes.
Because Tom did well down there and did the right thing.
Well, and when I started, they would come up on Tuesdays to the VA to teach us
right.
how to scope at the VA, because
right.
we didn't have any clinical people at the VA.
That's right. Yep.
And that was the day we would do an endoscopy at the VA in the morning, and then everyone came over for conference in the afternoon here in this very room.
Yep.
And they would stay for conference and drive back.
That's right.
And then we had to go down to Concord. To
work with them.
Work with them, right. It was a great experience, actually.
Yeah, I was very close to Tom Long and Bob Mitchell.
Well,
And Scott, of course, is a big golfer.
right. Well,
So.
you mentioned the IBD clinic, and I can't close the interview without saying how instrumental you were when I came and said I wanted to do inflammatory bowel disease. And there were plenty of people who said, what do you know about inflammatory bowel disease that the rest of us don't know? And I said, I think we can do this better. And you said, I'll do it with you. You know, you let me do it with you. And
Yeah.
I stood next to you in clinic, and when you retired, you handed me a beautiful array of patients with inflammatory bowel disease, many of whom I still see
That's great.
today.
Yep.
And I saw one this morning, and she asked about you. They never fail to ask about you.
Yeah, that's great.
And
That
so
makes me feel good.
You were not only a mentor and a role model, but you really helped my career, my career as it is. So
Great.
I'm
Good.
always grateful to you for that.
Thank you.